Good evening, delegates and speaker. Myself, Jagdish Chanjoshi, Senior Vice President, Baccalaureate Pharma Division, welcomes each one of you for this webinar, Prediction, Prevention and Challenging Case in PIH. Today, we have with us two eminent speakers to share their insight on PIH. We at Pharma Division Baccalaureate present you Labetalol, the brand of Labetalol. I am thankful to Dr. Pai and Dr. Chauhan for sparing their valuable time and their expert insight. With this, I hand over session to Dr. Mamta Jain for further proceedings. Thank you so much.
Thank you, Mr. Joshi. Thank you, Baccalaureate Pharma, for this unconditional support for the educational event. And I am sharing my slides for a faculty introduction, which is basically not needed. And when I see this, this is a word which is a sentence said to every introduction of every faculty that, oh, the faculty does not need introduction. But I would have never meant it, and this is very, very evident that you can see it today. It would have been no more pertinent, important, or relevant than as it is today. So today we have with us two eminent Indian gynecologists talking about management of hypertension in pregnancy. And when I say eminent, I would tell it across because a look at to their CV and you would know why I'm saying that. So we have Dr. Rishma Dilunpai. And what do I tell? With the top 3 hospitals in Mumbai, she is a leading gynecologist, be it Leelavati, Jaslok, Vichkandi. She's there at Hindujas. She has been a director and consultant with the Every Women Clinic, former president of MOGS, FOXY, ISAR, IAGE, and she's assistant treasurer of International Fertility Federation of Fertility Society. The only societies where it's left to become the president are probably the only international ones, which we are very sure will see it in the coming years. She's also the first Indian woman to have appointed as the board member of the World Endometriosis Society, like what I said, on the way to become president. So doing India more proud on that. She's been felicitated. I mean, her list of awards have been amazing. And 2021, she has been helping across with her CSR Health Impact Awards for being on ground to helping across all the healthcare warriors and heroes who have been there. She was awarded by COVID Essential Heroes Award. In 2020, the Glorious Legend, which is a FOXY Award at the AICOG 2020. In 2019, she received the Worldwide Achievers Award, which is in the specialty of healthcare's award. A very, very inspiring awards for and a role model for all the gynecologists in India. 2019, Inspiring Gynecologist of Western India. 2018, recipient of the Midday Health Wellness Award. Recipient of Women Empowerment Award in 2017, RCOG Research Center Award, Bharat Nirman Award for Women Entrepreneurship. She's also been a part of the 50 Outstanding Women in Healthcare Award in 2017 and recipient of Middle East Leadership Award 2016. She's also the recipient of Women Achievers Award. I mean, a list of awards probably can go across in pages and pages. We've not listed all of them because the whole time would go into that and we would actually not have time for the talk. So I'll not take much of a time. Introduce the second speaker later on before her talk. Hand over the mic to Rishma, Dr. Rishma Pai, for her interesting case series that she's going to be sharing it across to us. Dr. Pai, for you.
Thank you. Thank you so much. Just give me a minute while I share my screen. All right. Have I seen and heard? Can I be seen and heard?
Yes.
Good afternoon. Good afternoon to all of you. Thank you, Mamta, for those really warm words and a major introduction. Let me go on to say that we need to focus on more important things today, very, very relevant things today, things which can save lives. And that is the prediction and prevention of preeclampsia. Everyone knows that prevention, an ounce of prevention is better than a pound of cure. And nowhere does it hold more true or ring more true than in the prediction and prevention of preeclampsia, because we know that this is one condition which is the cause behind millions of women dying unnecessarily worldwide. So let us start with what is preeclampsia, and a very quick run through just to introduce the subject. All of us know it's a multisystemic disorder which originates in early pregnancy. Its pathophysiology involves maternal, fetal, as well as placental factors. The incidence is approximately 5 to 8% of all pregnancies worldwide, even more, up to 10% or more in India. It's the second leading cause of maternal mortality worldwide, and which is why I said it's so important to focus on predicting and preventing this condition. And of course, very often there are atypical presentations which can cause huge dilemmas in being able to diagnose this particular condition. Diagnosis, simple thing like a diagnosis, has changed dramatically since the last few years. And currently, what most of us use is the newer criteria, the revised criteria for preeclampsia. And very often, the International Society for Study of Hypertension in Pregnancy, that is the ISSHP, or the US Preventive Services Task Force, which is the USPSTF diagnosis, are used. And these are pretty common across many different definitions established worldwide. So what do these involve? Elevated blood pressure, 140/90 on 2 occasions, 4 hours apart after 20 weeks of gestation. So each part of this is important. At least twice you check the BP, and it has to be after 20 weeks of gestation. And either proteinuria, which is by definition more than 300 milligram per DL on a 24-hour urine protein test, or protein to creatinine ratio of greater than 0.3, or urine protein dipstick more than +1, if you don't have a quantitative analysis. And sometimes you may not even have proteinuria. So in the absence of proteinuria, if you have either thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or cerebral or visual symptoms, it is still preeclampsia. If the blood pressure is very high, 160/110, that is severe preeclampsia, then you can just reconfirm within minutes the same blood pressure and then immediately start therapy so as to prevent complications. So remember that the definition has changed. There is no mandatory presence of proteinuria required if you have other issues like renal or liver or thrombocytopenia dysfunctions present. You can classify it as the early onset, which is really the most severe form because it starts very early and it very often warrants delivery, which is in a state which is less than 34 weeks of pregnancy, and that obviously causes significant perinatal adverse outcomes. Or the preeclampsia may be late onset, in which case there is less severe maternal and perinatal adverse outcomes, as you can normally prolong delivery beyond 37 weeks. So whether the PIH or the preeclampsia is early or late onset is also very important. What is really the root cause of this particular problem? It's basically maldevelopment of the placental vasculature, leading to insufficient placental perfusion and hypoxia. And as a consequence of this abnormal placentation, there is endothelial damage resulting in hypertension. And of course, the adverse effects are huge. Maternal eclampsias, abruption, stroke, lots of problems, or perinatal, many growth issues, growth restrictions, low birth weight, intrauterine fetal demise, stillborn, etc. All of these, so a huge spectrum of consequences for this particular problem. Just to take you a little bit more through the etiology and pathophysiology, because only when you understand that can you actually look for ways and means to predict and prevent this. So we all know preeclampsia is really poorly understood, multifactorial. Basically, like I said, a placental dysfunction, the central pathology being abnormal placental development, maybe damage from diffuse microthrombus. There is a subclinical vasculopathy, since association of glucose intolerance and insulin resistance is also known. There is metabolic as well as immune dysregulation, and there has been an association with the BMI, with the fasting glucose, insulin, CRP, etc. So there are many different factors which go into the pathophysiology. Many different theories have been pronounced for this pathogenesis. Most common, of course, is the abnormal placental implantation with defects in trophoblast and spiral arteriole. There's a lot of focus on angiogenic factors, increased SLFT1, decreased placental growth factor, etc. There is cardiovascular maladaptation and vasoconstriction. There is even a genetic predisposition, maternal, paternal, even thrombophilias have a role to play, we all know. There is immunologic intolerance between the fetal, placental, and the maternal tissue. Platelets are activated, and vascular endothelial damage or dysfunction is very, very crucial and important. So you can see there's a whole range of etiologies and pathophysiologies, and which is why there is difficulty in finding one single predictive test or one single treatment option. There's a lot of hemodynamic changes due to hypertension in pregnancy. We can note always increased peripheral vascular resistance, inappropriately increased adrenergic activities. There is augmented responses to pressor drugs such as angiotensin, noradrenaline. There is impairment of normal increase in plasma volume, constriction of radial and spiral arteries in the uterine walls is seen, and of course the uteroplacental blood flow is impaired. And this diagram is just to tell you the complex hemodynamics behind this, from the cytotrophoblast invasion, immunological factors, poor placentation, maybe other factors like multiple pregnancies, macrosomias, thrombophilias, uteroplacental mismatch, atherosis, and then the cytokines, prostaglandins, all of them come in, placental debris, and you can see the various maternal syndromes that emerge from that, including cardiomyopathy, ARDS, edema, liver, renal damage, all kinds of multi-system effects. So it's an extremely complex issue that we are dealing with today. Given that background, how do we actually prevent? What are the strategies we can apply to prevent preeclampsia? Obviously, the only one main primary prevention would be to avoid pregnancy in women who are very high risk for preeclampsia. Obviously, that's not an acceptable option in most cases. And so we suggest modifying lifestyle or improving nutrient intake. But at the bottom line, majority of the cases are unpreventable. Of course, there is a possibility of secondary prevention, which is interrupting these known pathophysiological mechanisms of the disease even before it gets established properly. And one of the main keys we can use for this is aspirin administration. And we'll talk about that in a while. And of course, the tertiary prevention, which relies on the treatment strategies that you do, for example, using Maxalf to prevent eclampsia, etc. So what really is the rationale for this screening? What is the evidence behind it? The bottom line is that if we allow early detection and planning can be done of appropriate monitoring strategies, we can incorporate our interventions early. The US Preventive Services Task Force, I spoke about the USPSTF earlier, they found adequate evidence that screening for preeclampsia results in a substantial benefit to both the mothers and the newborns. And these are based on many, many trials. The Habitat trial 1 happened many years ago about whether we should deliver patients between 36 to 41 weeks. And it was found that if you deliver them in this phase when they have high BP, the results are much, much better for maternal and perinatal outcome. The Habitat 2 also came by later to study like between 34 to 36 weeks. And it was found that if the hypertension is moderate, you should try to delay delivery, not deliver immediately. So many different trials. The Magpie trial mainly studied the effect of Maxalf. So many, many different trials over the years have given us the concept that if you screen and you diagnose early, you can really give a lot of benefit to the mothers and to the newborns. So how do we screen? The typically a combination of tests as well as patient characteristics, extremely important. And this combination works better than a single test, because we've already mentioned that preeclampsia is heterogeneous in terms of causation and presentation. And so this is reflected better with 2 or more biomarkers, which are associated with different pathophysiological process, always keeping at the bottom line the patient characteristics. So because there's so many different etiologies, different tests may pick up different high risk factors. So our screening strategies, one of the most important things will be the history and the maternal characteristics. Then we have other important screening strategies. One of the main ones is uterine artery Doppler studies. Then, of course, biomarkers. They are available some places they're not available. But today in most metros, many of these biomarkers are available. So just running through a small list, you may or may not want to use all of them or may not have access to all of them. Most of these are the angiogenic or the anti-angiogenic markers. We have the pregnancy-associated plasma protein A, commonly available and widely used. You have the SFLT1, that is the soluble FMS-like tyrosine kinase, again, quite widely available. Placental growth factor, again, widely available. The soluble endoglin, just beginning to get used in our country. There are others like the ADAM12, that is a glycoprotein metalloprotease. There is homocysteine. There is ADAMA, which is the asymmetric dimethylarginine, uric acid levels, leptin, P-selectin, inhibin, activin, fetal hemoglobin, cell-free DNA, microDNA. All of these may give some sort of contribution towards screening and diagnosing patients early. Of course, the presence of urinary calcium, urinary albumin or calcium levels is important. So this one slide will tell you the amount of research that is going on in this area, the amount of biomarkers, the amount of other markers which are coming in to help us diagnose this condition early so that we can bring in preventive strategies. So unfortunately, we are in a low resource setting. India, being a developing nation, we have to rely on less tests and more clinical aspects. And so what are the maternal factors or history, which is extremely important to us? So we have to consider a pregnant woman of high risk if she has either one major factor, such as previous pregnancy, which had a hypertensive disease, chronic kidney disease, autoimmune diseases, diabetes, chronic hypertension, or a multifetal pregnancy. So one of these factors also will automatically categorize her into a high-risk patient for development of PE. However, if she doesn't have these high-risk factors, even if she has moderate factors, then you consider 2 moderate factors, such as her first pregnancy, or if the age is more than 40 or less than 90. So the extremes of age we know are high risk for development of preeclampsia. Intra-pregnancy interval of greater than 5 years, if the patient is obese with a BMI of 35 or more, family history of preeclampsia, if she's an IVF patient, we've noticed they have more tendency to preeclampsia, and if it's the first paternity. So 2 of these factors also put her into a high risk for developing preeclampsia. What about proteinuria? It has played a very important role, and we used to always associate proteinuria presence as a compulsory entity for diagnosing a patient with preeclampsia. But now we know that the use of urine protein dipstick reading device can be done. Every clinic can do it. Hospitals can do it. Significant proteinuria, however, is defined as greater than 300 milligram protein in 24-hour urine collection. This is equal to 3+ on your dipstick test. Then you can do more definitive tests if supposing you want to do a urinary protein to creatinine ratio or a 24-hour urinary protein collection. All of these are possible. But remember, like I said, no proteinuria does not rule out preeclampsia if all other maternal multi-organs are involved and are showing damage. Simple thing like measurement of blood pressure. And I've noticed even today, there is a lot of variation in the way blood pressure is measured. And because of that, there's a lot of misdiagnosis and inaccuracy. So measure the blood pressure using a mercury sphygmomanometer, calibrated aneroid device, or an automated BP device, which is validated properly. That's important. In a sitting position with the patient's arm at the level of the right atrium of the heart. The cuff size is important. It should be 1.5 times the circumference of the arm to be included. So in very obese patients, you need larger cuff sizes. And remember your Korotkoff phase 5 to be used to designate the diastolic blood pressure. So minor things like this of how BP is measured will also bring about changes in diagnosis. What are the other things? Like I said, important aspect of diagnosis and screening is uterine artery Doppler, because we have seen that there is an increased resistance to blood flow in the uterine arteries when associated with the development of preeclampsia. Because we've seen pathology of placenta in patients with preeclampsia, and you can see that there's a correlation between these placentae, the blood flow impairment, with the color Doppler changes. So you do a color flow mapping with pulse wave Doppler, calculate the pulsatility index, and this will give you a fairly good idea about the predictive value or the prediction of preeclampsia in the future. And remember that this uterine artery Doppler performs better in the second trimester than in the first trimester for identification of severe or early onset preeclampsia. However, very many times nowadays we are doing this analysis towards the end of the first trimester. So in the low risk population, a mean uterine artery Doppler pulsatility index could detect severe preeclampsia with a sensitivity of 78% and specificity of 95%. So that's a very good prediction by one single entity. But what are the limitations of screening with this uterine artery Doppler? It has a high sensitivity and a low specificity. And it is affected by many other things like maternal factors. And we spoke about that, the gestational age, the weight of the mother, the racial origin, whether she has diabetes, twin pregnancy, other risk factors. And you have to express it as a multiple of the median after adjustment of these factors. So it is a computerized program which gives us the final answer. A significant negative correlation exists with uterine artery pulsatility index, multiple of median, and gestational age at delivery. If you measure like we typically do at 11 to 13 weeks in women who later on will go on to develop severe preeclampsia. And we have a very nice preeclampsia risk calculator by the Fetal Medicine Research Organization. And this is available to use. It considers many, many different factors. You just have to enter in the data, and that will actually automatically, by a computer program, calculate the preeclampsia risk. And many units are now using that. So the implications really are that diastolic blood pressure, if you measure it in the early second trimester, 13 weeks onwards, is the most predictive parameter for preeclampsia with a positive predictive value of 2.8. So simple thing, mean arterial pressure, which is the systolic plus twice the diastolic divided by 3. If you calculate a mean arterial pressure, it is very, very predictive. So if you can do a combined screening, maternal factors considered, how age, how weight, etc., uterine artery pulsatility index, and the mean arterial pressure, just by these three simple things, you can identify 90% of pregnancies which will go on to develop severe preeclampsia, requiring delivery in the next 4 weeks. And this, like I said, is much better done at around 30-33 weeks than if you do it at 11-13 weeks. However, even early screening will help us to put preventive therapies in place. So very important also to know something about biomarkers, because we have actually started using them in our private practice today. These are angiogenic and anti-angiogenic markers. In a normal pregnancy with a healthy endothelial cells, you have a nice balance between the placental growth factor and the SFLT1. But when there is an endothelial cell injury, you can see that there is a complete imbalance between these two things. So these markers, the placental growth factor, vascular endothelial growth factor, these are members of the vascular endothelial growth factor family, and these are implicated in the actual trophoblastic invasion of the spiral arteries. So right when placentation starts, that's when the problem starts. The maternal serum levels of this placental growth factor at 11 and 13 weeks decrease in pregnancies with aneuploidies and those with impaired placentation. It also reduces in the second and third trimesters in those who are going to develop small growth, growth restricted babies, or those who are going to develop preeclampsia. So one single marker, again, placental growth factor is an important marker, and its low levels will predict a poor outcome for mother and child. Then you have factors such as the soluble FMS-like tyrosine kinase called the SFLT1. And you also have started using now the soluble endoglin, that is SENG factor. These are the, we have seen in this, the levels of these increase 5 weeks prior to the onset of preeclampsia. So if supposing a lady is going to develop preeclampsia at around 30 weeks, at 29 weeks, at 34 weeks, at 29 weeks itself, you will see these factors rising. And a combination of second and third trimester markers, the SFLT and the placental growth factor ratios, will give you a good detection rate, almost 88% at a fixed false positive rate of only 10%, and you can diagnose early preeclampsia in these populations. So biomarkers definitely add value in mapping progressive disease and helps you to do good surveillance and risk modulation, and you can actually try to avert the awful outcome of severe preeclampsia. Another important marker is the PAP-A, pregnancy-associated plasma protein A. We've been using it already as a screening test for genetic abnormalities. This is a large glycosylated protein produced by the developing trophoblastic cells. The low levels of PAP-A are associated with higher incidence of preeclampsia and fetal growth restriction, typically because of the poor placentation. So if you do a first trimester PAP-A and a second trimester SFLT, placental growth factor, combined first and second trimester, you can predict late onset preeclampsia with a detection rate of 87.5%, very low false positive rate. So with 2 or 3 markers, you can get an excellent prediction for development of preeclampsia later on. Genetic biomarkers, of course, we are really not using very much in practice today, but we do know that the mode of inheritance of predisposition to preeclampsia is polygenic, and the meta-analysis has shown that there's a high risk of preeclampsia with coagulation factor 5 gene. Human Genome Epidemiological Review has shown that. So just to show you some reviews about the amount of work that has gone into giving us a first trimester combined effective screening method, from 10 different tests put together to very minimum tests put together. So let us take the study by Wright et al. In 2012. A priori, just for your information, is like a prediction or a, sort of a telling from the history or the background how you can predict a particular situation. So this is mainly maternal factors, her weight, her age, her previous history, etc. So when you consider maternal factors plus uterine artery Dopplers and mean arterial pressure, you can get an early preeclampsia prediction of 80% and late preeclampsia prediction of 55% with only a 5% false positive rate. If you add 1 or 2 more markers, for example, PAP-A and placental growth factor, this goes up to 93 to 96% prediction with very low false positive rates. So as you keep on adding the markers, which we've discussed before, you may be able to get more and more accurate predictions. However, from this study, we can see that if you can combine the history of the patient, mean arterial pressure, uterine artery Doppler, placental PAP-A, and placental growth factor, you can actually predict more than 95% the onset of preeclampsia. And so the cost of this is very, very important in the Indian scenario. The cost of this first trimester combined screening, beta-HCG, PAP-A, placental growth factor, integrated with the risk of the age, mother's characteristics, etc., uterine artery pulsatility index, etc., maybe 2,000 if you're in a smaller town, maybe 4,000 to 5,000 in a big city like Mumbai. So it depends whether we can really offer this to the patient because of the cost factors. So if we can incorporate the maternal characteristics, the history, uterine artery Doppler, mean pulsatility index, you can actually get a very good risk for preeclampsia by the preeclampsia risk calculator. So just this basic, without going into many biomarkers, etc., the simple and cost-effective recommendation can be given, and you can get very good prediction. So what are we suggesting? Maternal characteristics, clinical history, uterine artery pulsatility index. And you can put it on the PE risk calculator and get a pretty good prediction. Once you're predicting, how do you prevent? Not too many magical things available for prevention. One drug that all of us use is aspirin. Aspirin should be given to women 150 milligram daily as per recent recommendation in 2017. Start it early on in pregnancy before 16 weeks and take it at night and continue till delivery. This will give a significant prevention of the development of preeclampsia. Calcium is important. A simple thing like 1 gram calcium supplementation is recommended. This is obviously also our FOXY recommendation. So what is the screening algorithm in a low resource setting? Because that's what we have to focus on. That's the resource we are in. And so take the mother's characteristics and history, look for the major factors, like I said, whether she has a previous history of hypertension, autoimmune disease, multifetal pregnancy, chronic hypertension. See if we have one of the major factors or two of the moderate factors, like if she's older or very young, if she has a long interpregnancy interval, she's obese, etc., or she's an IVF pregnancy. So take these factors and then see if she's screen positive. Then you can put her into the preeclampsia risk calculator, like I said, given by the Fetal Medicine Organization, or you can offer the combined screening with the biomarkers if the patient can afford it. So you can do all of these things, Dopplers, you can do biomarkers, or you can just do a history and background screening. So if your screen is positive, start your prevention strategy, start aspirin 150 milligrams before 16 weeks, add calcium, keep on monitoring her very, very closely, and then, of course, deliver her as per recommendations. Don't forget simple things, how blood pressure has to be measured with a proper instrument, the cuff size has to be appropriate, patient has to be sitting, arm has to be at right atrium level of the heart. That is how blood pressure has to be taken. The fifth Korotkov phase sound has to be heard as the diastolic end point. And for proteinuria, also, these are important things because these are in our day-to-day practice we encounter. Remember, either you can use a dipstick, significant proteinuria, 300 milligrams in 24 hours, and otherwise you can do the protein to creatinine ratio. These are all our FOXY guidelines as well. And remember, if there is no proteinuria, does not rule out preeclampsia. So let me conclude by saying that preeclampsia is a complex, heterogeneous disease, has many varied presentation. The prediction of it has to be based on multi-parametric approaches because we know the multi types of different etiologies that it has. The maternal characteristics, clinical history is the mainstay in low resource settings to identify women who are at high risk. Aspirin, 150 milligram before 16 weeks of gestation and 1 gram of calcium per day is a helpful agent in prevention of preeclampsia. Screening for preeclampsia, which combines maternal characteristics, history with biomarkers, along with the pulsatility index on color Doppler, performs more efficiently than other methods. But there are, of course, limitations of cost. And we do need many more studies to identify ideal combination of markers that we can use for routine screening in even a low-risk population. So I think once more and more studies comes in, we can apply these screening to every single patient, low risk or high risk. Lots of references here. Thank you very much. I hope I've tried to make this little complex subject reasonably simple. Thank you.
Thank you, Dr. Pai. Thank you, Dr. Shma. Really, this was a very informative presentation. What you rightly said at the start of it, saving lives, it's a very important topic. And coming down to the next speaker that we have it across. And like what I said is, just a moment, let me just share my screen. The second speaker also speaks across. So from learning the basics of PIH, now we go into how do you manage in real life and what better than the case-based approach to understand that. For that, we have Dr. Anahita Chauhan. She's a honorary consultant with SEFI in St. Elizabeth. She is former professor and HOD with GS, head of, not HOD, I would say unit head with the GS Medical College and KEM Hospital. Who wouldn't know KEM Hospital and the legacy of it and the kind of professors and HODs which come out from them, the kind of academic legacy that they carry on their head. They're born teachers, and that's what we have in perfect opportunity to learning from her. She has been a vice president with MOGS, with former secretary MOGS. Like what I said, as postgraduate teacher for more than 30 years of experience in one of the most premium institute of our country. First joint editor of Journal of Obs and Gynac of India, numerous publication and clinical trials, and field of interest, high-risk obs and adolescents health, contraception and urogynecology. Over to you, Dr. Chauhan.
Thank you, Dr. Mamta. And if you will just allow me to share my screen. So Dr. Rishma has beautifully shown about the prediction and prevention. Is my screen visible? Is my screen visible?
Yes, absolutely.
So after hearing Rishma, who took us through the prediction and prevention of PIH, I would now like to quickly go through some challenging cases and look at the guidelines for the best practices. Before I start, I would like to say that everyone may not know, but today, 22nd of May, is World Pre-Eclampsia Day. And I think it's very appropriate that my talk today is on the challenges that we still face after decades and decades of studying about this disorder. We know that hypertensive disorders will occur in about 12 to 22% of all pregnancies, but the severe cases are seen in a much smaller percentage for us. We're going to start right away with the cases. And the first case, I put that though this is supposed to be challenging, it's not challenging as much as it is controversial. We have a 26-year-old primey. She's had an uneventful antenatal course. She comes at 28 weeks. And at the 28 weeks, her BP is 140/92. Prior to this, keep in mind the BP was normal. She doesn't have any symptoms or proteinuria. So I would classify this patient as either a gestational hypertension or a mild hypertension. And definitely, I would not jump to admit her. The old-fashioned view was to give salt restriction, bed rest, and sedatives, but currently this does not hold much water. And all studies have shown that there is no benefit from salt restriction, bed rest, or sedatives in preventing the mild hypertension from becoming severe. And similarly, there is no role of early initiation of antihypertensive therapy in these patients. In fact, antihypertensives could compromise the fetal perfusion. Very often we are worried that we are managing these patients at home and we think, should I start a low dose of antihypertensive? And the answer is definitely no. So for a mild hypertensive, I would not start antihypertensives, but we'll look at the next question. At what blood pressure would I then like to start my antihypertensive therapy? So the American College clearly states that treatment of women with uncomplicated mild or moderate hypertension is not beneficial because it does not improve the perinatal outcome. A lot of debate on when to start. And as I started this case by saying it's not challenging so much as controversial. So there is definitely no controversy. In case I have a patient with chronic hypertensive who's already on antihypertensives, or I have severe hypertension, or eclampsia, obviously I would start antihypertensives. But for mild hypertension, where the blood pressure is between 140 to 150 or even 160, or the diastolic is just between 90 to 110, do I really need to start or not? That's the question. If we see all the international guidelines, it seems reasonable to conclude that I should start when the systolic BP is at 150 or more and the diastolic is at 100 and more. This is a very important point because my aim is not to make her normotensive or even hypotensive. My aim is to bring down her blood pressure just below 140/90. In fact, the NICE guidelines say 135/85, and to further bring down the blood pressure would jeopardize the fetal circulation. If we had to study the antihypertensive agents available to us, the good old drug which we grew up using was alpha-methyl dopa. And then, of course, the series of other drugs like nifedipine, labetalol, etc. And today I'm going to focus a little bit on just telling you about the common drugs which we use. Alpha-dopa can be given up to 2 grams per day in divided doses. And we usually start with 250 milligrams up to 3 or 4 times a day. The action does take some time to occur, and there are known side effects like postural hypotension, etc. Labetalol is the one that we are most comfortable with today, and we typically would start it in the dose of 100 to 200 milligrams twice a day, ideally a BID dose, and in very severe cases, we would step up to TID, that is going to 400 milligrams thrice a day. Nifedipine, retard, etc. can be given up to a dose of 80 to 90 milligrams per day. And hydralazine sometimes is not available, but we can start with 10 milligrams 3 times or 4 times a day. Labetalol, as I said, we should start with 100 milligram twice daily. Here I want to emphasize that there is no role of giving 50 milligrams labetalol, which I have seen some practitioners give. If you do want to begin, please begin with 100 milligrams twice a day. It's a perfectly safe drug, and even for home monitoring, it's a good drug to give. And then you titrate every few days to a maximum of 1200 per day. Try to avoid cross pharmacy. So use one antihypertensive for moderate or severe initially, and then add the second one if required. Labetalol reduces the peripheral resistance. It ensures a quicker, better control of blood pressure. It's very well tolerated. And in many studies, the maternal and fetal outcome have been better in the labetalol group compared to methyl dopa. The next question to ask in the mild hypertensive patients is, do we need to give them magnesium sulfate to prevent eclampsia? And here I want to quote the MAGPIE trial, which was done almost 15 or 20 years ago, where the inclusion was uncertainty whether MAGSulf would work or not. So definitely it did work in reducing eclampsia, but the number of patients needed to treat was very large. And so the recommendation was for mild hypertension, there is no role of MAGSulf. So I now move on to the next case. And this is very commonly seen in practice, that one fine day you have a 30-year-old primigravida. She's come to you, uneventful course. Suddenly at 32 weeks, her blood pressure has gone through the roof, 170/110, and she has 2+ proteinuria on the dipstick. Definitely, I would classify this as severe preeclampsia, and I would look at what investigations to do and whether I should admit her or not. Of course, the answer is I will admit her. So Rishma did touch upon the expanded definition of preeclampsia. And I want to say that now when we look at the expanded diagnosis and definition, we should understand that all the investigations we do are to make sure that we look at renal involvement, hematological, hepatic involvement, and so on. Definitely the proteinuria, elevated creatinine, the start of oliguria, which is sometimes seen in our severe preeclamptics. Thrombocytopenia is sometimes a feature. Even gestational thrombocytopenia is known to occur, but we should look out for severe thrombocytopenia as well as an elevated LDH, which would point to a HELP syndrome. The hepatic involvement is apparent with elevated transaminases and also the elevated alkaline phosphatase. In the complete picture of preeclampsia, eclampsia, the neurological involvement is extremely important, and we should always look for the clinical signs like severe headache, visual disturbances, etc. What are my priorities in management of a case of severe preeclampsia? The first and foremost is I should admit and observe and diagnose correctly that this is severe preeclampsia. I have to look at both the safety of the mother as well as the fetus. And the first thing I should do simultaneously is start antihypertensives and prevent convulsions by starting magnesium sulfate. After I have stabilized the patient, I should make sure that I avoid or prevent complications. Most important is eclampsia. We all know that the incidence of preeclampsia has remained the same through the decades all over the world. But what we can and should do is reduce the incidence of eclampsia, which is very much in our control. Apart from the maternal condition, of course, we must assess and promote fetal well-being and then plan the delivery at the correct time. So all hospitalization is recommended if it is a case of severe preeclampsia where the systolic is more than 160 and the diastolic is more than 100 and there is proteinuria. Even if there is only proteinuria and epigastric pain or any of the other symptoms suggesting an impending eclampsia like vomiting, visual disturbances, etc., we must hospitalize the patient. Keep in mind that sometimes primi gravide with a blood pressure of even 140 or 150 over diastolic 90 or 100 will still throw an eclamptic convulsion. So the prompt action should be to recheck the BP after instituting antihypertensive therapy. Severe systolic hypertension in the range of 170, 180, 200 and so on is an independent risk factor for stroke. So it's not just eclampsia that we are worried about, but it is also stroke and other cerebrovascular accidents. Failure to treat the severe systolic hypertension has been identified as the single most serious failing in the clinical care of women who died. And this is what WHO has stated more than 10 years ago. So if I have to acutely control a severe hypertensive, today I have IV Labetalol, which works wonders. We can start with 20 milligrams IV over 2 minutes. Monitor the BP after 10 minutes. And if the BP is high, I can even give 40 milligrams, keep monitoring the BP, and I can go up to 80 milligrams in small bolus doses. I can even do an infusion with 1 to 2 milligrams per minute, and this will help to control the severe hypertension within 20 to 30 minutes. In case I don't have IV Labetalol, I can try oral nifedipine. There is no role of sublingual nifedipine, or I can even try IV bolus of hydralazine. Very often we are in a dilemma that after I have controlled the blood pressure and after I may have instituted magnesium sulfate, when should I deliver her? Should I deliver her urgently or should I wait? Should I wait for the BP to settle and take a decision? Always remember, delivery is always appropriate therapy for the mother, but may not be so for the fetus. So in the past, our teaching was whatever gestational age, severe hypertension, terminate the pregnancy. But currently, we do have a conservative approach in select cases, and the conservative approach will only be in the fetal interest and not in the maternal interest. So prompt delivery we know is curative, and it will avoid possible adverse effects to both the mother and the baby. On the other hand, if I have a significantly preterm infant, prompt delivery will land that baby in the ICU with a significant morbidity and mortality. There is very clear consensus in all the guidelines that after 34 weeks of gestation, delivery is the ultimate cure. And as soon as the mother reaches 34 weeks, or if she becomes hypertensive after 34 weeks, we should not wait. At the same time, if I am dealing with an emergency case, I should not rush to deliver. I should control the BP. I should prevent convulsions. If I have a preterm infant, I should give corticosteroids. I may decide to wait 24 to 48 hours and then deliver the patient. Western literature, of course, is full of severe preeclampsia remote from term. But our guidance clearly says that any baby after 26 or 28 weeks, we may try expectant management provided the maternal condition is stable. After 34 weeks, we should just stabilize the patient and deliver. And below 28 or 26 weeks, depending on which center you are in and the capability of the neonatal team, you should terminate the pregnancy. Of course, the fetal monitoring is equally important with NST, fetal count, and as Rishma mentioned, the Doppler assessment twice a week, amniotic fluid index, and ultrasound to look at the fetal weight. If I have a patient who is less than 34 weeks, I should deliver her immediately if the hypertension is uncontrolled despite treatment, or she develops symptoms of cerebral irritation despite giving her magnesium sulfate, or she has other complications of severe preeclampsia like HELLP syndrome, pulmonary edema, renal impairment, etc. Of course, the fetal parameters need to be closely monitored, and needless to say, the patient should be admitted in a tertiary care center. Oligohydramnios, low birth weight, reversed or absent umbilical artery diastolic flow, all of these would be indications to deliver this patient earlier than even 34 weeks. Now comes MagSulf. We all know that MagSulf is life-saving. In severe preeclamptics, we must institute MagSulf within the first 24 hours when we are evaluating her. And it also has a role during induction and postpartum. Severe preeclamptic cases, we must give it if patient has any signs or symptoms of imminent eclampsia. Also, the added important benefit that magnesium sulfate acts as a neuroprotector for the fetus, especially the ones at 30 to 32 weeks. It's now a standard practice for us to give magnesium sulfate for 4 to 6 hours prior to delivering these patients. The route of delivery is extremely critical. Cesarean section is not the answer for all severe preeclamptics. Cesarean section is reserved for those where there is a clear obstetric indication, as well as some other problem like Dopplers, which are not good, or CTG, which is not good, or a poor biophysical profile. I now move on to my third case. And this is the one that we all dread and we all don't want to see in our labor rooms. A 19-year-old primigravida, 8 months previously unregistered. She's brought by her neighbors with the episodes of convulsions at home. She's in an altered state of consciousness, but she's responding to commands. Her admission BP is 200/140. She has 3+ proteinuria, and she's not in labor. Pregnant patient with generalized tonic-clonic convulsions, your first diagnosis, unless proved otherwise, should always be eclampsia. Sometimes patients will come with a referral note where you should have some idea about her previous history, but blood pressure and urine albumin will be the key with this diagnosis, and your confirmation of the diagnosis should be done in less than a minute. Of course, there are differentials like epilepsy, CVAs, a space-occupying lesion, metabolic disorders, or infection, but these are to be discarded in the face of a clear-cut eclamptic convulsion. RCOG has beautifully said that the principles of care revolve around 4 things which should be done: the control of seizures, investigations, antihypertensives, and delivery. And control of seizures, institution of antihypertensives therapy, and investigations should begin simultaneously. Once the patient is stabilized, you can move on to planning the delivery. When we have a patient who is actively convulsing, all institutes now should have an eclampsia drill in place. They should have an eclampsia kit which is ready, stocked and checked periodically, and they should ideally have an eclampsia room as well. Avoid injury, maintain oxygenation, and minimize the aspiration during the convulsion. Initiate max self-therapy and control the blood pressure. The recommendation is you can load the IM max self. In the meantime, somebody else starts the IV line, draws blood, and then gives the IV loading dose as well. So in the first 30 minutes, I can't overemphasize magnesium sulfate and antihypertensives. For control of seizures, the last word is magnesium sulfate. It is recommended for both the prevention and treatment of eclampsia and severe preeclampsia in preference to all other anticonvulsants. The full IV or IM regimen is recommended. Some people like to give only IM if she's not convulsed, only IV, half the dose, etc. But the universal teaching from WHO, Government of India, and all other agencies is please give the full IV and IM dose. In case you are in a facility where you can't monitor the patient, you can safely give the loading dose and immediately transfer the patient to a higher center. You can either use the classic Pritchard's regime, which is an IV loading with IM in maintenance, or the Zuspan regimen, which is a completely IV regimen. Many of us prefer the Zuspan regime because you can avoid the abscesses with magnesium sulfate. In patients with thrombocytopenia and DIC, you want to avoid intramuscular injections, and Zuspans can be very well controlled using a syringe or an infusion pump. About 13% of women will have recurrent seizures even despite magnesium sulfate, and you can repeat the 2-gram IV if it has been more than 15 minutes from the loading dose. If you have to resort to phenytoin, phenobarbital, etc., this patient is definitely better managed in either an HDU or an ICU. Apart from bringing down the blood pressure, the antihypertensives will help to prevent cerebrovascular accidents, cardiac failure, abruption, HELP syndrome, etc. Now, in an acute situation, again, my choice of antihypertensive would be nifedipine, IV labetalol, hydralazine. I don't have much experience with NTG, but that can also be used. In a chronic situation, I could use any of the tablets orally, but my first choice would be labetalol in combination with nifedipine. I will avoid diuretics and ACE inhibitors in all the severe preeclamptics. We should all be on the lookout for a hypertensive emergency or a hypertensive crisis when we have patients who have had a convulsion. And in acute situations, the WHO review says that no particular agent is definitively better than another. Labetalol and nifedipine are equally effective, and both are more effective than hydralazine. Nifedipine has the fastest onset of action, but the maternal side effects are least with labetalol. In an emergency convulsing patient, I can send CBC and platelet count, liver renal function test, and an entire full coagulation profile. When will I deliver this patient? In cases of eclampsia, there is no role for conservative management, and I will deliver her promptly. And LSCS, I would reserve only for obstetric indications. Again, delivery is the ultimate cure. And my indications for C-section in these patients would be if vaginal delivery is not possible in the next 6 to 8 hours, especially because I'm worried about a worsening maternal condition, or I have an unconscious or uncooperative patient, or a preterm patient, or any fetal problem like distress or reversal of flow. General anesthesia is ideally to be avoided because it can add to the maternal risk. Epidural or spinal is very safe, but you have to avoid the regional block in cases of thrombocytopenia or potential coagulopathy. In case general anesthesia is given and the patient is already on magnesium sulfate, keep in mind that magnesium sulfate potentiates the action of the neuromuscular blockade. So you will require to give less of your relaxant when patients are on magnesium sulfate. Previously, the anesthetist would be very wary of giving anesthesia when patients have just received a magnesium sulfate dose, but anesthesia can be instituted at any time when the patient is on magnesium sulfate. Very often, if at small primary center, you have a patient who is very bad or critical, it's better to transfer. But when you want to transfer, ideally control the blood pressure, give the first dose of antihypertensive, give the first dose of corticosteroid if it is a preterm delivery, measure the urine output, put in a catheter, give the loading dose of Maxalf, and transfer after confirming that there is availability of either ICU or HDU as well as an NICU for the neonate. And so I'm going to very quickly go through the last case because it is just an extension of complications which can occur. The same patient is on Maxalf, she's catheterized, there's no urine, and the nurse panics and rapidly infuses her. By the time you see her, she has bilateral crepitations on auscultation. The uterus is tense, tender, and the fetal hearts are absent, and there's fresh bleeding. And so apart from eclampsia, the important point to understand that fluid should not exceed 80 ml per hour in these patients who have a very constricted intravascular volume. There is no role for diuretics routinely, except if you want to give a diuretic challenge if the patient is in renal failure, or she has massive pulmonary edema or cardiac failure. These are the only instances where diuretics would be used. And so this case has progressed to fetal demise with abruptio placenta, with renal failure and pulmonary overload, fluid overload. So when would you involve the ICU specialist or the intensivist? Very often, the intensivist will be quick to tell you to do a CT scan or an MRI. And in patients with recurrent seizures or a focal neurological deficit or a very poor unresponsive general condition or visual disturbances, a CT would be indicated. If she has refractory oliguria or even PRES, that is the posterior reversible encephalopathy syndrome, definitely we should be doing an MRI or a CT and admitting her in an ICU. Just the last couple of slides on HELP syndrome, which we all know. We should be very quick to correct HELP syndrome in patients with elevated LDH, low platelets, and elevated liver enzymes. We should deliver these patients quickly, so we should replace factors and deliver these patients. Acute fatty liver of pregnancy, unfortunately, is a condition where there is a high morbidity and mortality, and patients progress rapidly to hepatic failure and hypoglycemia. So maternal mortality in eclampsia can be because of a cerebrovascular accident, pulmonary edema, renal failure, or DIC with multi-organ failure. Unfortunately, maternal mortality in cases of eclampsia is still a reality and contributes significantly to the overall maternal mortality in our country. 40% of mortalities occur postpartum, and so we must continue to monitor these patients in the postpartum period as well and taper off antihypertensives gradually. Here I would like to mention that methyl dopa can sometimes cause or compound postpartum depression, and methyl dopa should be the first antihypertensive to be tapered in the postpartum period. So to conclude, women with severe preeclampsia should be managed aggressively or transferred. If remote from term, they may be offered expectant management in very select cases. Eclampsia is life-threatening, and all units should be geared to manage it swiftly and efficiently, and magnesium sulfate is still and will continue to be the drug of choice. I thank all of you for a patient hearing, and this is the list of references from where I have drawn. Thank you.
Thank you, Dr. Chan.
Thank you.
We have very, very engaging audience today. Around 2,000, more than 2,100 doctors have logged in. And the kind of questions which have come across, I'm sure that the next half an hour, 1 hour is going to be very, very engaging. What I've done is I've copied these questions into a slide and I'm just sharing it across with you.
Right.
Is my slide visible?
Yes.
Yes.
So what right day, as Dr. Pai and Dr. Chauhan highlighted, 22nd May being World Pre-Eclampsia Day, and 2,100 gynecologists across the country have logged in. So a few of the questions which have come across, which is there. So a typical case scenario, which is there, at her first prenatal visit, a 31-year-old gravida has a blood pressure of 100 by 60, no proteinuria, normal weight for her gestational age. She enters the third trimester, BP rises to 138 by 86. She now has proteinuria 1+. She's gained 10 pounds in the last 2 weeks. What do you think? Should it be? How should it be diagnosed, not diagnosed, pre-eclampsia? How does the findings reflect in the last trimester?
So essentially, she does have gestational hypertension, but it is really very mild, 138 by 86. I don't think much needs to be done except close monitoring. She has 1+ proteinuria, so again that can be monitored. The weight gain is probably just water retention and edema. Since she's already 32 weeks, I think we monitor her closely and maybe give her steroid just in case her blood pressure gets worse and she is requiring to be delivered a little before time. So if we can kind of monitor her carefully, give her, even start aspirin, it may have a low role to play, start her if the blood pressure goes higher. At 138 by 86, you don't need any hypertensive. If it goes higher, 140, 100 or more, you may want to consider starting Labetalol. So I think we can safely take this girl with good monitoring, ultrasound Dopplers, investigation, safely take her to a phase when the fetus can be born safely, 34 weeks plus for sure, even more, probably 36, 37 weeks.
Yeah. Dr. Chauhan, you would want to add something here?
I wanted to add that before making sure that we only label her as a gestational hypertension, I would like to do baseline investigations. Because if any of the investigations is abnormal, like liver function or renal function test, then that may point, or even the CBC or platelets, that could point to a mild preeclampsia. I would also do a urine routine analysis because sometimes a UTI can also have proteins in the urine. So here I would like to thoroughly investigate her and then just monitor her. And also maybe a sugar because she could also have a gestational diabetes to account for her weight gain.
Okay, perfect. Point well taken. So we go across to the next question. Is there any relationship between vitamin D deficiency and preeclampsia?
So vitamin D is now the new kid on the block who is implicated in just about everything from PCOD to menopause. So there's definitely a role with calcium and preeclampsia, which is very well documented. And sometimes calcium absorption is hampered if the vitamin D is low. So it's worth correcting vitamin D irrespective of the preeclampsia or otherwise.
I think the more documented studies are with calcium, and that is why we really underline that as a preventive measure, give calcium 1 gram per day to the patients right from early part of pregnancy. So, calcium probably has a more direct relationship and vitamin D possibly has a role to play.
So we have been having a lot of talk about this primordial prevention of that. So is it that in utero preeclampsia chances of metabolic syndrome and cardiovascular in the offspring? I mean, what do you think about it?
Yes. The Barker's hypothesis, which has been doing the rounds since the last 20 years, it's very well documented that ischemic heart disease, adult onset diabetes, adult onset obesity are seen, but it's not typically with preeclampsia as much as it is with small for gestational age babies. Of course, the consequence of preeclampsia is small for gestation or growth restricted fetuses. And those are the fetuses who do land up with metabolic syndrome and cardiovascular in their adult lives.
So lots of
So
correlation.
the next,
A condition like polycystic ovarian syndrome, for example, been studied so much, and it is really now found that it is this intrauterine exposure, small for gestational age, and after delivery, rapid catch-up of growth. These are the factors which predispose to PCOS and also metabolic syndrome, which we know is an offshoot of that. So there are many implications for preterm babies, those who develop RDS, long-term development of respiratory and lung conditions, small for gestational age developing all these metabolic syndromes. So there are lots of issues of in utero exposure to all kinds of illnesses, not only preeclampsia.
so this late onset preeclampsia, I'll take it across later on because there is one more question which we can combine it and take it across. So again, you've answered it, but this question has come up again and again. Is labetalol or methyl dopa better first-line antihypertensive?
So,
what do you think?
So 30 plus years ago when Rishma and I were coincidentally doing our residency together at KEM Hospital, labetalol had not even come on the market, or it had just come. So we were very comfortable using methyl dopa. But in a hospital setting, methyl dopa is okay where you give it 3 or 4 times a day. But now there are numerous studies which say that labetalol is definitely better than methyl dopa, especially in terms of the side effects and the control that it achieves. And secondly, if I do have a patient with, say, moderate preeclampsia who I'm managing at home, then labetalol is a better option because the dosage is more convenient, the drug is safer to take at home. So I would say today labetalol becomes the easy first line, and methyl dopa I would reserve for patients who are really not responding to labetalol.
I agree completely.
Any thoughts here?
Labetalol has taken over as first-line drug also because of the convenience and ease of, taking it as a BD dose and safety profile. And, it's an alpha, beta, both actions. It's not centrally acting like methyl dopa. So, the centrally acting drugs have more sort of side effects and consequences. Labetalol has been shown to be a safe drug, even in as high as 1200 milligram per day doses. So today, definitely labetalol, and in fact, the reverse has happened now. Methyl dopa availability has become less because almost everybody is using the labetalol.
So now this is again a very valid concern which has come across. Overcorrection of blood pressure with any antihypertensive agent is possible, resulting in reduced uteroplacental blood flow. So how important is this concern?
And all of us have underlined that, and Aita has also underlined that. I have that. Don't try to reduce the blood pressure to completely normal. Keep it in the range of around 135 to 85. That is the recommendation by the NICE guidelines. 140/90 also is acceptable. So don't overcorrect because it will definitely impair the uteroplacental blood flow. Yeah. So no dramatic drops in blood pressure.
What I feel, Dr. Mamta, is that as obstetricians, we are better qualified to manage mild and even severe preeclampsia. The moment we involve a physician, they are quick to want to bring down the blood pressure. So don't involve a physician because it's easy for us to manage up to severe preeclampsia and even eclampsia. It's only when you anticipate complications that you should involve either a physician or an intensivist, because their natural tendency is to bring down the BP drastically.
And also natural tendencies to start diuretics. Yeah. Most of the physicians tend to start diuretics right away, and that we know is not to be recommended. So I think we can probably do a better job in this scenario.
Now, both of you in your position with the society heads and various positions as both at national and international level, you have to create policies which not just is valid at a big city hospital or cities, but at the rural impact. So now, if you have to give across few takeaway points for any of the rural towns or towns which do not have that kind of thing, and an acute setting control which comes across for a blood pressure in pregnant patient, how do you tell them? What do you monitor? I mean, what are the basic things that probably could be of concern?
I think it's really, even in a rural setting, this is one condition where you can be in almost all circumstances in control if you have a good antenatal care. So fortunately, even in India today, people are all over the country are having hospital deliveries as a preferred mode of delivery. So if they're doing regular checkups, you can predict, you can prevent to an extent high blood pressure, you can monitor. The moment you see that the blood pressure is really going into the severe high blood pressure range, patient is going into a sort of a severe condition, you can either transfer her into a more sophisticated care center, tertiary care center, or of course your blood pressure medications can be started. Neither Labetalol, Methyl-Dopa, Nifedipine, all are not expensive drugs. That's a good point. They're all oral drugs. So oral medication, low cost medication, easily available medication will help you to control situations, initially. And the moment you find that things are getting out of control, BP is becoming too high despite medication, proteinuria is 3+ or more, patient is having any kind of symptoms of neurological symptoms or headaches or epigastric pain or any such thing, immediately stabilize and send to a tertiary center. So already we have mentioned about how to stabilize and transfer to a main center. So I think today there is no excuse, even in a rural setting or a small setup, to have a neglected patient of preeclampsia, unless the patient has just not come to the doctor at all and is confined to her home. Then it's a different situation.
Dr. Chauhan, you are on mute. You have to unmute yourself.
I'm unmuting. Sorry. I want to add a couple of things that at an organizational level, FOXI has a GCPR, a good clinical practice recommendation, which is across the board for urban, rural settings both. There is also a Gestosis Society, which has a hypertensive disorders in pregnancy training course where they have gone across the board training gynecologists all over the country. There's also enough Government of India recommendations along with WHO and UNICEF who have gone literally to centers and trained them on use of MaxSelf. Also, eclampsia drills are a part of a lot of training programs for emergency obstetric care. So EMOC programs, which have been supported by, the National Rural Health Mission or any of the big government agencies, has also promoted eclampsia drill training, also promoted the use of MaxSelf in the standard dose. That's what we can do at an organizational level. The other important point is we have to emphasize to smaller centers that magnesium sulfate loading dose is safe, and all the problems or potential problems of magnesium toxicity only occur with the subsequent doses. So the loading dose is absolutely safe. You are not going to push a patient into renal failure or even cardiac arrest with your loading dose. It's only the subsequent doses which require monitoring. The third point which Rishma made is that all ANC clinics, whether they are at a primary health level or not, will at least do the two basic things: weight, blood pressure, and albumin. Three basic things. So weight, blood pressure, and albumin, these three things alone will help to pick up the moment you have a patient with a high blood pressure. And then, of course, transfer early rather than late.
Thank you so much. So the next question is, you've covered that angiogenic markers, if not available, what do you do?
I think, in urban settings, people are now using a lot of biomarkers, but essentially it is not required. If you have a good background, and I've already sort of underlined high risk factors, medium risk factors, whether she has a previous history of hypertension, family history, twin pregnancy, obesity, all of these factors, if they're there, you're already alert to that. Along with that, if you can do mean arterial pressure, that itself, just so the history factors, risk factors, mean arterial pressure will already be able to predict to quite an extent. If to that you can add a color Doppler pulsatility index, then I think these three will be giving you almost 80+% prediction for further development of preeclampsia. So you can already get your preventive measures into place, and you can sort of make sure that this patient is, monitored more closely than another patient because she's high risk for development of PE. So your biomarkers and antigen markers are not mandatory.
Perfect. And when do you start labetalol in mild PIH, which associated with severe IUGN?
I think I have mentioned very clearly that in mild preeclampsia, there is no role of antihypertensives. So each international agency has given different cutoffs, but I think 150, 100 and below, she doesn't really need the antihypertensive. At 150, 100, you begin the antihypertensive therapy.
Now, which comes across, late.
Labetalol is not going to help in the severe IUGR anyway. So only for the hypertension, 150, 100 and above, you should begin.
So now this is on the late diagnosis, which we are coming up with. BP 200, 110 at 8 months. What do you do? Maybe 170, 90 at 24 weeks. How do you manage? I mean, 6 months, 8 months, how do you do it? So you've already talked about it, but maybe you would want to retouch it.
So there are two aspects. One, I did not mention about the chronic hypertensive. So sometimes we can have patients who enter pregnancy known hypertensive on treatment. That's the only time where you would involve a physician to switch to pregnancy-safe antihypertensives. Sometimes these patients could have superimposed preeclampsia, and sometimes we could see this as early as 24 to 26 weeks. It becomes very challenging in terms of whether to terminate pregnancy or not. But if I had a known hypertensive at 24 weeks with very high blood pressure, I would try to pull on by controlling the blood pressure. If she did have signs and symptoms of proteinuria, oliguria, etc., there's no question I would terminate.
Fair enough. And how early can we add aspirin in a patient with a severe PIH? When would you want to start it?
Definitely, aspirin is proven to be fairly safe in pregnancy. In fact, many times we are starting it even pre-pregnancy or in very early pregnancy. For example, in patients with recurrent pregnancy loss, sometimes patients have a very thin endometrium. Even before they become pregnant, we give them aspirin to improve the endometrial blood flows, etc. So if there is a very high-risk patient whom you know has a significant risk of getting into pregnancy-induced hypertension later on, we should start her on aspirin earlier. Definitely by the end of the first trimester, before the second trimester starts, but in certain cases, maybe even before that.
Perfect. Can you give nifedipine in pregnancy?
You can, only for the convenience of dosage. You can, depending on the situation. So if it is a patient who has a severe hypertension and you're continuing the pregnancy for whatever reason to gain time for the fetus, you could switch her to retard after having given nifedipine orally initially to control the high blood pressure.
When do you terminate pregnancy in severe hypertension?
I think this is a very, very broad question. It has to be very individually decided. We all know that severe hypertension is a ticking time bomb, and it depends on the maternal condition, her blood investigations, her liver, renal function, coagulation profile, baby status, fetal distress or not. So I think there are many, many factors, fetal maturity, a lot of factors which will go into deciding about terminating pregnancy. But if the risks are high and the patient is more than 34 weeks pregnant, then definitely give her a steroid injection and deliver the baby. There's no point continuing after 34 weeks if the blood pressure is very, very high or the patient is very high risk. If even earlier than that, if there is severe fetal distress or if there's severe impending eclampsias, you can terminate pregnancy. So I think this has to be taken on a individual basis.
I think the mistake that people make is they pull on the patient without doing the due diligence in terms of maternal and fetal investigations. If I am taking a conscious decision to pull a patient, say, from 30 weeks to 34 weeks, then I have to repeat certain investigations weekly. I have to repeat certain investigations twice weekly. I have to see that my neonatal setup is capable of delivering and managing a 1 kg or a 900 grammer baby. only then I would go ahead with this course of treatment. So it has to be very individualized.
So the next question, we've already talked about the safest antihypertensive in the talks also, and also I'll just skip that. How do you differentiate clinically between eclampsia and first episode of seizure disorder?
So most seizure disorders are known pre-pregnancy, and the incidence of seizure disorder actually occurring de novo for the first time in advanced pregnancy is almost unheard of. So she has to have a history of seizure disorder. Yes, sometimes we will have patients who have hidden this history from their in-laws or have stopped taking their anti-epileptic medication because they don't want anyone to know. In those cases, it might be an epileptic fit and not eclampsia. But of course, it's very clear, a clinical definition, the blood pressure, the albumin, the hyperreflexia will all point to eclampsia. And pregnancy itself will be your first and most important decision to say this is eclampsia and not epilepsy. Subsequently, if with magnesium sulfate she does not get controlled and you have to start her, say, on phenobarbital, then you may want to further evaluate her for a seizure disorder if magnesium sulfate has failed.
Okay. So now this is a different question. When signs of organ damage are seen in investigation, even though the patient has a normal blood pressure, especially high-risk patient, can we start level?
I think that the problem is anything, organ damage is not equal to PIH or preeclampsia.
Yes.
It could be many different things. It could be acute hepatitis. It could be fatty liver of pregnancy. It could be, so it could be any other disorder causing organ damage, any systemic infections, anything. So I think you can't just label any organ damage is equal to high BP. So if there is signs of preeclampsia, if there is proteinuria, if there was history of high blood pressure, or at least slightly elevated BP or something to suggest that, yes. Otherwise, it could be a differential diagnosis for many other things.
Yeah. Agree.
Can we stop? Sorry, Dr. Chauhan, you want to add something?
I completely agree.
Can we stop magnesium sulfate after 24 hours and continue pregnancy in case of severe preeclampsia if BP is controlled and patient is stable?
Again, this would depend on why you wanted to continue the pregnancy. So theoretically, yes. Practically speaking, unless you are in a tertiary care center or a high dependency unit and the patient is really being monitored and there is a valid reason to continue the pregnancy. For example, she's between 28 and 32 weeks and you want to pull on, yes. Also, if she has had an eclamptic convulsion, no. But if she's severe preeclampsia, there have been many reports of giving magnesium sulfate and then waiting for a week or 10 days and then delivering the patient. So I would say, again, in a very controlled situation with close monitoring, it's possible.
And what is the maximum dose of labetalol that can be given per day?
So I'm not comfortable exceeding 1200 milligrams per day, which is the recommendation. The toxic dose is around 2400 milligrams per day. If after 1200 milligrams, I feel that the blood pressure is not controlled, or even before that, based on the blood pressure, I would be more comfortable adding a second antihypertensive, preferably nifedipine, and staggering it through the day. So if I'm giving labetalol twice or thrice a day, in the intervening hours, I would add a nifedipine maybe twice or thrice a day. So that round the clock, the patient is covered and her BP comes under control.
And essentially, then this patient is already moved into a really high risk sort of a category where you're probably not going to prolong the pregnancy too long. If you're requiring multiple drugs to bring her blood pressure down at topmost doses, I think this patient eventually needs to be prepared for an earlier delivery.
Perfectly fine, and what an evening well spent. I mean, learning from you, both of you, and taking across the whole journey of managing hypertension in pregnancy is amazing. Thank you so much for sharing your time. And Mr. Joshi, would you want to come in?
So it was really very interesting, nice session. Even non-medical personnel like we have also understood a lot about the PIH, and I definitely expect all the viewership, that's more than 2,000, they must have benefited with the lots of insight by Dr. Chauhan and Dr. Pai. On behalf of Macleod, I thanks both of you, Dr. Mamta for moderating so nice way, and all the delegates is sparing their valuable time. Thank you so much. Requesting wherever possible, we have a brand Labetalol, that's brand of Labetalol, which you all have said, one of the most preferred drugs. So please patronizing this. Thank you so much.
Thank you.
Thank you,
Thank you to
Mr.
all of
Joshi. Thanks, Macleod's entire team. Thanks, Leah and Ekta from Medvist for coordinating and getting it done. Thank you, Dr. Pai, and thank you, Dr. Chauhan, for sparing so much of time in the evening on Saturday. Have a great weekend. Be safe, everyone. Enjoy yourself.
And thanks the entire Medvist team, and of course, marketing team from Macleod also. Okay, thank you so
Yes, thank you so much.
Thanks a lot.
Bye. Good evening.
Thank you.
much. Thank you so much. Good night.